So maybe we can start now. So good morning, good afternoon, and good evening, seniors and colleagues. And today is again our ACNS YNS webinar. Today we have Professor Katos with us, and our chair today would be Professor Ahmed Ansari, who is the Assistant Professor of the Department of Neurosurgery of Jawaharlal Nehru Medical College in Aligarh, India. So our speakers today, for the expert speaker, we have Professor Kimura Sensei, who will be talking about the anterior crinoidectomy. And our YNS speakers today is Dr. Farhad Ahmed, who will be talking about the microsurgical clipping of intracranial aneurysms, days of future past of a young neurosurgeon. And our second expert speakers today will be Professor Igor, who will be talking about the treatment of complex vascular malformation with or without intracranial experience. Our discussion today is a Professor Olisan and also a Professor Ahmed Farad and Prison. And along with me is Dr. Sachin Atik and also Dr. Sukati and also Julie Sam to moderate this section. So shall I invite our chair, Professor Ahmed Ansari, to chair our section and introduce our speakers.
Ahmed.
Please.
Hello, Ahmed. Can you hear us?
Yes, please unmute yourself.
Dr. Ahmed, can you hear us? Can you please unmute?
Yeah. Can you hear me now, Raja?
Yes, we can hear you. Please continue.
Yeah. So, hi everyone. It's been a pleasure to be here on the ACNS YNS session. And it's my pleasure to introduce Professor Kimura. And Professor Kimura is an, I think, just a second. There is some problem coming in here.
Okay, maybe shall I introduce the first expert speaker, Professor Kimura Sensei, and then I will continue with the next two speakers. Professor Kimura Sensei.
Yeah, it's fine here. So,
Department of Neurosurgery in Kobe University Graduate School of Medicine in Kobe, in Japan. So he's also he will be talking about the anterior crinoidectomy today. So shall I invite Professor Kimura Sensei to share his screen? Professor Kimura Sensei, please unmute yourself.
Oh, sorry. You can see. Can you see the slide?
Yes.
Okay. Thank you for your kind introduction, Dr. Ansari and Dr. Ben. And yeah, it's my great honor to be invited again this fantastic ACNS YNS webinar. And great pleasure for me to see you, all my colleagues in this webinar here always. So I deeply appreciate Professor Yoko Kato and for inviting me again. So today I'm asked to present regarding the, the anterior crinoidectomy. So I will talk about in detail. So first I need to explain about the anatomy of the anterior cranial process. And after that, how to perform the anterior crinoidectomy using the cadaver head. After that, I will show you two clinical cases using the anterior crinoidectomy with a paracrinoid aneurysm. So this is the anatomy. You have to know in detail about the anatomy of the anterior cranial process. Anterior cranial process is located medial end of the sphenoid ridge here, and the posterior projected bony structure, This bony structure connected to three surrounding structures, you know the superior orbital fissure, roof of the superior orbital fissure, and medial, you can see the superior medial connection is the roof of the optic canal. So, and the final third connection is a so-called optic strut. Optic strut is located just under the optic nerve, optic canal. So to remove the anterior crinoid process, you have to drill out or longe out 3 bony connections. First, you have to remove the supraorbital fissure connection, and next you have to remove the unroof of the optic canal here. Finally, drill out the optic strut. And if after that, you can remove the anterior crinoid process totally. And you have to know, sorry. When do we need to perform the anterior crinoidectomy? Mainly, you have to perform for the paracrinoid aneurysm or some basilar, upper basilar aneurysm, we have to perform the anterior crinoidectomy. And some skull-based tumor, and in a selected tumor, if I have to perform the anterior crinoidectomy. So to perform the anterior crinoidectomy, you have 2 ways to remove the anterior crinoid process: extradural removal or intradural removal. You can choose 2 ways, but mainly I choose the extradural removal because this extradural removal obtained a wide surgical field to manipulate the surgery. So, but limited case, mainly in the skull-based tumor around 12 gram I perform the intradural removal after removing the partial removal of the skull-based tumor. But today, I may talk about the extradural removal for treat the paracrinoid aneurysm. So you have to know anatomical structure, very important point. I have to express important point. You know that dura consists of the 2 dura layers, periosteal dura and the dura propria. Usually, the surface dura consists of, the 2 dura layers. And the periosteal dura reversed just lateral edge of the superior orbital fissure, reversed into the orbit. And the dura propria connected to the lateral wall of the cavernous sinus. So you just cut the periosteal dura at the lateral edge of the superior orbital fissure. So you can dissect this plane. To know this anatomical important point, to remove the anterior crinoid process, step by step was shown here. First, you have to remove the detachment dura widely and skull base from the detachment of the dura. Frontal base and temporal tip was dura was detached. And drilling of the orbital roof and widely, and the meningoorbital band was cut just incising the periosteal dura. And optic canal canal roof was drilled. And this connected 2 bony structure. And finally, you have to drill out the anterior crinoid process and remove the anterior crinoid process totally. So I want to stress the important point. Dura consists of 2 dura layers. The periosteal dura reversed into the orbit like this, and just incising the lateral edge of the supraorbital fissure here, you can approach to the lateral wall of the cavernous sinus. Important point. I will show you in the cadaver head. So this cadaver is performing the left front temporal craniotomy. This is frontal and temporal. This is exposed the lateral edge of the supraorbital fissure, so meningoorbital band exposed. Just incising the periosteal dura, and you can approach to expose the lateral wall of the cavernous sinus, and there also lateral edge of the anterior cranial process. And the roof of the supraorbital fissure was drilled out, and medial to this process, you can see the optic canal unroofing here. and the anterior cranial process was drilled. In the clinical case, you have to avoid a heat injury to the optic nerve. You have always to irrigation mandatory to avoid the heat injury to the optic nerve. This is the tip of the anterior cranial process. After that, you can expose the all anatomical structure. This is IC carotid siphon here, and this is lateral wall of the cavernous sinus, third nerve, fourth, and the V1 nerve here. And this is the optic strut, remaining part of the anterior cranial process connection. This drilling is very, very dangerous to always take care of the optic nerve and the carotid siphon. Don't injure during this drilling. And you can see that this distal drilling penetrates the IC carotid artery, extradural in the intradural. This is a distal drilling. And the ophthalmic artery is always running just under the optic nerve, you can see. And the circumferential incision around their carotid artery. And to doing this manipulation, the carotid artery can be mobilized. And you can access to the medial to the carotid artery here. So again, I will show this is the cadaver head. This is an illustration. First, you need to expose the meningoorbital band, lateral edge of the superorbital fissure. Just inside the periosteal dura, you can this is incising along the inferior border of the superorbital fissure, so you can expose the lateral wall of the cavernous sinus. Also, you can expose the lateral edge of the anterior cranial process. As I mentioned, you can expose to the lateral wall of the cavernous sinus, and this is the carotid siphon here, and this drawing was circumferentially incised. You can approach to the medial to the carotid artery, even in the medial to the carotid artery. So this is a clinical case. This patient is a 59-year-old female suffering the paracranial aneurysm. This aneurysm projected ventrally, you can see here. So, CT angiogram demonstrated the aneurysm dome is projected downward, and overlay the CT venogram can identify this aneurysm located. The tip of the aneurysm may be located inside of the cavernous sinus, but the neck, around the neck exists in the cistern. So we have to perform there to clipping to avoid a rupture to cause to a subarachnoid hemorrhage. So the patient's spine position and the clamped using a Mayfield clamp. And the front temporal craniotomy. As I mentioned, I'm drilling the orbital roof and roofing is now performing. And just inside, this is the meningoorbital band here, and just inside in a periosteal dura, and elevating the dura propria. This is the lateral wall of the cavernous sinus, and exposing the lateral edge of the anterior cranial process. Recently, I use a micro rongule to most part of the anterior cranial process. This is the roof of the optic canal, and the micro rongule removing the roof of the optic canal, and you can see the tip of the anterior cranial process. After removing the final part of the anterior cranial process, dural incision was made. Just linear incision along the Sylvian fissure was sufficient to expose the aneurysm body. This is you can see the optic nerve here. And this is the aneurysm itself, aneurysm dome. The tip of the aneurysm was protruded inside the cavernous sinus. This dural ring was expanded due to the aneurysm itself. And the meticulous, and you can see that sometimes you need to expose the higher magnified inspection, taking care of the not to injure the aneurysm dome. And finally, you can expose the aneurysm neck, and the clip was applied. And ICG confirmed the disappearance of the aneurysm. Endoscope also confirmed the braid. The remaining part of the neck was clipped also. And post-operative CT angiogram, CT, no hemorrhage, no infarction, and the CT angiogram, obliteration of the aneurysm completely. And the second case is a 51-year-old female, also paraclinal aneurysm. This aneurysm projected superiorly, you can see here. So what is the difference ventral superior? The important point, this aneurysm detached to the anterior cranial process directly. So just removing extradural removal, sometimes you may encounter the aneurysm injury. To avoid the injury of the aneurysm rupture, we have to partial removal, extradural partial removal. After dural opening, confirming the aneurysm dome, and the final removal of the anterior cranial process is very, very important technique. So as I mentioned, exposing the lateral edge of the anterior cranial process, the orbital unroofing here, and the drilling of the anterior cranial process partially. The tip of the anterior cranial process was remained untouched. The first, I need to expose the aneurysm dome here. This optic nerve, aneurysm dome here. And after that, I can remove the final part of the tip of the anterior cranial process, taking care of the not to injure the aneurysm dome. This is the aneurysm itself, and circumferentially, this drawing was incised, and you can expose the total circumferentially exposed of the aneurysm neck. And the clip was applied. The CT angiogram demonstrated obliteration of the aneurysm itself. So this is take-home message. In training, every young neurosurgeon have to know about the skull-base anatomy. Of course, if possible, you should perform the cadaver dissection. And of course, you have to experience, as an assistant experience, very important to perform the actual surgery. In the actual operation, we have to always be aware of normal anatomy, what will exist over there. And inspection of the microanatomy under the high magnification is very important, without any bloody field. Makes the bloodless surgical field a very important point. And finally, never give up to achieve the purpose of the surgery. Important point for the surgery philosophy. Thank you for your attention.
Yeah, excellent presentation, Professor Kimura in here. I was especially interested for the second case that you showed in here, which was when the aneurysm was attached to the anticlinoid process, the ventrolateral, the ventrally projecting one aneurysms. Specific thing, do you have any specific recommendation if there is a fusiform dilatation of the cavernous portion of the ICA projecting in the form of an aneurysm? How do you decide whether you have to go for a reconstruction of the cavernous ICA segment or involving your intervention colleagues to go for an FD?
Thank you for your question. You mean the cavernous portion of the internal carotid artery aneurysm, you mean?
Yeah, if there is a fusiform dilatation.
Fusiform dilatation.
Yeah, fusiform dilatation of the cavernous ICA. What is your recommendation of going in for a reconstruction of the cavernous ICA segment or going involving your neurointervention colleagues for an FD in that cases?
Thank you for your question. So we have to distinguish between the intradural component and the extradural cavernous component aneurysm. Very totally different. You know, in the case with a symptomatic cavernous aneurysm, IC cavernous aneurysm, can be treated recently. In Japan, we treat the patient for diverter, and some in the traditionally we need to do the high flow bypass trapping ICA for the symptomatic cavernous fusiform aneurysm. But the asymptomatic case in the cavernous portion IC aneurysm, you need to touch, just observe the patient. If the cavernous aneurysm are asymptomatic, I think.
Yes, sure. Thank you.
Thank
Are
you.
there any more questions for Professor Kimura in here?
Yeah, if I may say, hello, can you hear me?
Raja, please. Yeah, Raja, please.
Yeah, hi,
Go ahead.
Kimura Sensei. Thank you very much. It was such a
thank you.
wonderful
Thank you.
talk. Regarding your choice for extradural or intradural clinoidectomy, like extradural has a marginal advantage of exposing the ICA 0.6 centimeters more than the intradural. And also, as a general rule that is said in vascular surgery for paraclinoid aneurysms, which are very close to the clinoid, it is better to do it intracranially when you are a beginner. But when you are an expert like you, it is both. It's not. This rule doesn't apply to you. But when for a beginner, when you are doing a clinoidectomy, better to visualize the aneurysm and then perform the clinoidectomy.
Yeah.
And also, extradural is the when you do clinoidectomy for other reasons. When you have a tumor and you have PCOM aneurysms. PCOM aneurysms, like when the neck of the aneurysm is less than 7 millimeter from the clinoid, they recommend to do a clinoidectomy. So when it's a PCOM aneurysm or aneurysms for other, when you are a beginner, it's better to do extra. It's better to if when close to the clinoid, better intradural. You see the aneurysm so that your drill doesn't touch anywhere. So that is one comment I would like to make. Once again, thank you very much for this wonderful.
Thank you for your comment. Nice comment. Yeah. Yeah, Raja, I totally agree with you. So for the beginner, some chance to encounter emergency to need to perform the anterior clinical process. So in such a situation, you can choose the intradural removal of the anterior clinical process just after expose the aneurysm body. But in some cases, please very pay attention to drilling. Intradural drilling is very dangerous. Sometimes the drill skip away and the optic nerve and the ICA don't injure the ICA. So drilling intradural is very dangerous. So yeah, we have to know about it. Okay.
Yes, and also the pre-op CT images are very important to see the occurrence of where there is a middle clinoid process. So there may be an accessory foramen. So when you try to mobilize it without drilling it, you may tear off the carotid. So accessory foramen also you have to root when there is a middle clinoid process.
Yeah,
Thank you.
Thank you.
Thank you, Raja, Professor Kimura. Are there any further questions for Professor Kimura here?
Sir, can I ask a question?
Yeah, please go ahead.
Thank you, Sensei. It's Dr. Shahnawaz from Dhaka, Bangladesh. Sir, very basic questions I want to ask. When do you consider orbitozygomatic craniotomy instead of terminal craniotomy when you go for ACP drilling? This is number one. And how much neck extension and contralateral rotation you prefer for ACP drilling, like in PCOM or paraclinoid aneurysm?
So you mean the contralateral? What do you mean contralateral?
I mean, sir, how much neck extension and also the rotation of the head to the
何をど
contralateral
のくらい
side?
頭を傾けるかってことを聞いてると思います。
Oh, I see. I see. Thank you. About 30 degrees and 30 or 45 degrees. Not so standard rotation to the contralateral side. And the very important point is you mentioned is to just perform the anterior cranioidectomy. You don't need to do the front orbitozygomatic approach. Just only a front temporal craniotomy. You are standard front temporal craniotomy, and you can even with the anterior cranioid process. Don't remove the zygoma, don't remove the orbiter, just perform it from temporal craniotomy. You can remove the anterior craniotomy process. As I
Okay.
presented in the slide. Yeah, thank you.
Okay, sir. Sir, one question, sir. How much neck extension you prefer for positioning the patient?
Positioning, extension.
Yeah.
Positioning is usually what I mentioned about 30 degrees rotation, the contralateral side. How do you mean extension?
今度は首をどのぐらいの
Extension. I see.
Yeah.
Because not so specialized here, especially care. Usually, you have to care about the heads up, patient heads up, taking up care about the drainage, venous drainage of the usually the jugular vein. Don't cross the compress here is very important, of course, but it's not a matter to this surgery. It's a standard position. It's okay.
Okay, sir. Okay. Thank you, sir.
Thank you.
Thank you, Professor Kimura, for having us today in here and for enlightening the first session in here. Now, I think we'll proceed with the second speaker for today. I would like to invite Dr.
Please unmute.
I would like to invite Dr. Farhad Ahmed, who is presently working as an assistant professor of neurosurgery at the National Institute of Neurosciences and Hospital.
No. Sorry.
No, excuse me.
2 more questions. Dr. Sam and Dr. Ben.
Okay, yeah.
And also the Wozniak.
Hi, Prof. Kato. Thank you so much.
Hi, how are you?
Well. Thank you. Prof. Kimura, excellent, very short and very precise. I learned a lot from that. I've done a few anterior clinoidal drillings before, and okay, 2 questions. Question number 1, I always have problem with bleeding from the cavernous sinus when you drill, and that actually disturbs the process a lot. Do you have any tips in reducing or tackling that problem? That's first question. And second question, if it's a pneumatized clinoid, anterior clinoid, will that be a contraindication to perform the clinoidectomy? Thank you.
Yeah, thank you. Good question, Dr. Sam, and thank you for your giving great important point. So the first question is to, sorry, can I say?
カバーナスサイナスの止血に何かグルーを入れるとか、みたいなことだと思います。
Important point is just the heads up is very important first. In such an encounter, the cavernous bleeding, you have to heads up the patient, of course, and widely known the fibrin glue is effective. Just tiny cottonoid soaked fibrin glue soaked tiny cottonoid was inserted to the anteromedial portion, bleeding point of the cavernous sinus. But the too much fibrin glue hinder the surgical manipulation to clipping apply, of course. The heads up is very important. So, and of course, the tiny volume of the fibrin glue to achieve the hemostasis. Some neurosurgeon inject the fibrin glue directly to the cavernous sinus, fibrin glue. But I don't recommend, some neurosurgeon recommend us to perform the fibrin glue injection to the cavernous sinus directly. But I don't recommend that manipulation. Just a heads up and a tiny volume of the fibrin glue is sufficient to achieve the hemostasis from the cavernous sinus. Too much fibrin glue is to hinder the surgical manipulation, I think.
All right.
Make sense? Okay, thank you.
Yes.
Professor Wozniak, please.
So,
Sorry,
okay, have you finished with the answers about, I think, Professor Kimura, I think you have not finished with didn't answer to the pneumatized clinoid. Yes? Yes, then another question. Yes. Okay, I'm waiting.
Really? Thank you. For the pneumatized anterior clinoid process is, of course, not a contraindication. When you encounter the opening of the pneumatized sphenoid sinus, just insert a tiny volume of the tissue, or sometimes the muscle piece or some kind of fat tissue from the temporal fat. Using the tiny volume of the fat tissue is inserted, and the fibrin glue is attached closed and a pneumatized sphenoid sinus. You have not encountered the post-operative CSF leakage. No problem, I see. But important point, yes.
Yeah,
of course.
right.
Yeah, and it's important point to remove the anterior clearance process. You have to know preoperatively that in sometimes connected to the posterior clearance process or interclearance process. This is a variant of the anterior clearance process. Very important point. You have to know about the tip of the anterior clearance process. Its connection, some another bony connection is no or no. You have to know about the preoperative CT, 3D CT. Okay.
Okay, thank you. Thank
Thank you.
Yeah, Professor Wozniak, please.
Yes, I see that Ben has a question. Yes, Ben.
Yes.
Do you have a question?
Yes, just a quick question, and Julie Sam just asked one of my question about the using the sphenoid sinus, but another question of me is about cutting of the dual wings. So for the extradural cynodectomy, so is there any tips for opening to separate the distal and the proximal dual wings? How do you cut the dual wing towards the ophthalmic artery? Is there any tips? Because in extradural, because you already remove the kind of process before you open the dura.
Yeah.
So my thinking is that we cut open the falciform ligament, and then we use the space between to separate the distal and the proximal wing. But what is your tips or way of tackling the cutting of the dual wings?
Yeah. Thank you, Ben. This is an important point you mentioned. So this cutting the dual ring is sometimes very dangerous. So first important point to have the bloodless surgical field. If some bleeding occur, of course, as you mentioned, cavernous bleeding is not a preferable condition to incision, the circumferential incision, carotid and distal dual ring. So after achieving the hemostasis and the clear surgical field, you have to incise the distal dual ring, and medial incision around the distal dual ring, you can encounter the ophthalmic artery, origin of the ophthalmic artery. So at that point, you have to very care about the high magnified inspection and the bloodless surgical field, and you can visualize the ophthalmic artery directly, and then you can incise the distal dual ring medially. Without confirming the ophthalmic artery, you don't need to incise the medial portion of the cavernous distal dual ring. Okay. So confirmation is ophthalmic artery first, is just under the ophthalmic artery important. After that, you can slowly medial incision along the distal dual ring, and you can incise the dual ring totally.
I see.
Of course, preserving the ophthalmic artery. Very important point. Thank you.
Yes. Thank you so much.
Thank you.
Professor Li Sang, please, your comment.
Okay, thank you, Professor Kimura. Thank you very much for great talk. Very illustrative with the cadaver and with the clinical presentation. It's great. Let me comment something, maybe add something and extend a little bit the clinoidectomy for tumor cases. So it's mostly addressed to our younger colleagues. So I completely agree with you that the extradural way of clinoidectomy is much more safe than intradural. It's really, first of all, because it's very difficult to have orientation in the wound when you go intradurally. Another way, there is a dangerous of damage of some anatomical structures like optic nerve or arteries. Then the bone detriment, you leave the bone detriment inside of the arachnoid space. It's also not good for the patient in the future. And the last one, of course, if you penetrate the clinoid clinoid and enter the sphenoid sinus, it's much more difficult to prevent the CSF leakage if you go intradurally. It's much easier when you go extradurally. It's my first comment. Then let me talk about the tumor surgery. Tumor surgery, it's a little bit different because when we use the clinoidectomy for aneurysm, we work with the normal anatomical structures. It's real normal anatomy. In case of clinoid meningioma, in case of cavernous sinus meningioma, we deal with pathological anatomy, and it has some specific in manipulation inside of the wound. And the first problem is the excessive bleeding during surgery, because the meningioma has a very good blood supply, and the main blood it receives from medial meningeal artery. That is why I always recommend to block this artery, to coagulate and cut. Not only coagulate, but coagulate and cut this this artery before separation of 2 layers of dura. This is the first step. Once you block the medial meningeal, you will decrease the bleeding, I think, in 80%. It will become much, much, much less. Then another step, when you separate the dura propria temporal dura, sometimes it could be quite difficult in the tumor cases because the tumor invades both layers. And as you show in your case, it's very important to dissect the meningo-orbital ligament only with a sharp way. Never try to dissect to start in the blunt way. You will get bleeding, you will get the penetration of the dura, you will lose the anatomy. The first step is only sharp way. When you dissect sharply by a scalpel this ligament, you will get access to the 2 layers, and then you can go on with a blunt way. You can dissect 2 layers. What is very important, even when the tumor invades both layers of meninges, anyway, you can separate them, and if you will move along these 2 layers, you will never penetrate the cavernous sinus, and you will never damage all the nerves of the superior orbital fissure and the cavernous sinus. It's very important. So you can dissect all the temporal dura together with tumor, resect it completely, and leave the piece of tumor inside of the cavernous sinus for radiosurgery. And so in this way, you can prevent the damage of the neural and vascular structures inside of the cavernous sinus. You told about CSF. I actually agree with you. It's not a problem. You can put some fat, some glue, and you can close this always. And that's all. And my last recommendation, to attend dissection courses to start clinoidectomy on the cadaver specimens at least 2 or 3 times before you will start doing in clinics. So thank you very much. And once more, Professor Kimura, thank you very much. Great presentation. And my congratulations. Thank you.
Thank you, Professor ৱ্যস্নায়ক. A great comment. Totally agree with your comment. Yeah, thank you. Thank you.
You're welcome. You're welcome.
Ahmed?
Ahmed, can you introduce our next YNS speaker?
Yeah, sure. Can you hear me on? Yeah, thank you, Professor Kimura, and all the participants in the discussions for the first portion. Now I'd like to invite Dr. Farhad Ahmed, who is presently working as an assistant professor of neurosurgery at the National Institute of Neurosciences and Hospital at Dhaka. He is also a fellow at Fujita Health University Bantan Hospital, Nagoya, Japan. And I would like to invite him for his next presentation. Dr. Farhad, please.
Yes, I'm sharing my screen.
Sure.
Do you hear me?
Yes.
Do you see my screen now?
Yes, yes.
Thank you, Professor Kato Sensei, for giving me the opportunity to speak on this platform. And first of all, I would like to thank and congratulate Professor Kimura Sensei for delivering such a nice basic concepts on anterior clinoidectomy. And my today's talk is on microsurgical clipping of ruptured aneurysm. As a perspective of days of future past of a young neurosurgeon, of a beginner perspective. I am working as assistant professor in neuroscience hospital. Now I am currently at Fujita Bantan Hospital at Nagoya doing my fellowship. This is my hospital from Bangladesh, Dhaka, Bangladesh. This is where I come from to Japan. So, subarachnoid hemorrhage is caused by rupture of intracranial aneurysm, has a far worse prognosis, and 12% of patients die before reaching the medical centers. During the last few decades, newer diagnostic techniques and treatment strategies have been developed for patients with aneurysmal subarachnoid hemorrhage, leading to a decrease in the case fatality by 0.6% per year. However, the case fatality rate of subarachnoid hemorrhage is still reported between 8.3 to 67%, with most patients dying as a result of the initial bleed or its immediate complications. So it's a retrospective analysis, what I'm going to show that in the last 1.5 years of the management of ruptured aneurysm cases at a single unit of our hospital. And all patients of all age groups who presented to our institute referred from neurology unit with ruptured intracranial aneurysms were included. And patients with subarachnoid hemorrhage due to any other cause were excluded from the study. The age, sex, presentation interval, that is interval from bleeding to presentation to our institute, GCS, WFNS score, and other comorbid illnesses were recorded. And a CT scan done on presentation or done at a primary hospital was evaluated, and presence of hydrocephalus or subarachnoid hemorrhage related vasospasm were noted. The baseline workup and pre-anesthesia checkup was done in all patients, and all patients underwent 4-vessel CTA on the basis of the suspicion site, and DSA done on CTA negative patients or on whom further information needed regarding aneurysm morphology. So what are the institution protocol of referral? From ER, patient got admitted into stroke unit or neurointervention unit. Then the patient referred to us with a referral paper, and patients with low GCS and high Hunt and Hess grade were managed conservatively initially to upgrade the condition, as well as management of CSF diversion if needed prior to the primary surgery. GOS assessed at discharge and 3 months follow-up at OPD clinic. In our series, some of the patients couldn't come for follow-up, contacted through cell phone or video call. So this is an archive, a database of our unit, where we enter the data and save it for further usage in future. And this is a central server archive where we can access from anywhere on the world. And our total cases were 80. ACOM cases were 56%. MC aneurysms were 23%, and DACA 6%, IC aneurysm 6%, vertebral basilar 1%, and multiple aneurysm 7%. Our average age was in our study was found 53 years, male to female ratio 1:1.5. We divided the presentation interval according to 3 groups: less than 1 day, 1 to 3 days, and more than 3 days. In our country, most of the patients come usually within 3 days, after 3 days or 1 to 3 days. And in our series, admission to clipping time averaging 7 days. And we found comorbidities which were recorded: hypertension 32 patients, diabetes mellitus 25 patients, ischemic heart disease 11 patients, previous CVD 2 patients. We found 2 hydrocephalus patients in our series and prior to the primary surgery, and infarction in 2 patients. So how do we plan our cases. In our unit, we before the surgery, we sketch the aneurysm morphology within ourselves. We sit together with the surgeons, and we study the A1 dominance through the CTA angiogram or CT scan or MRA, and also we study the A to A to fork anatomy, MCA bifurcation, 3D orientation, and we plan the craniotomy accordingly. Also, we dramatize or imagine the clip maneuvering. What would be on the OT? We maneuver it pre-operatively on prior to the surgery day. And also we think about the handedness, which hand to apply the clip finally on the pre-operative day. So these are the some sketches we do usually on the pre-operative day. These are the images at our institute. We demand for the 3D CT angiogram from the radiology department, and we study it with a CD. So regarding the clip application, we first on the preoperative day, we simulate within ourselves in an imaginary manner how we should apply the clip of that particular aneurysm, considering the three movements of the clip, clip, shank, and shoulder. That is roll, yaw, and pitch. And this is the yaw, this is the rolling, and this is the pitch. These three movements are important during the final application of the clip. And also we study the how our hand should be landed with the clip applicator to have a clear sight of line vision of the dome and fundus. And keeping in mind that our clip landing site may be a plain land, maybe it may be on a tilted land. So our landing depends on the various factors. These factors we discuss prior to the day of the surgery. And then we sit with the patient. We counsel the patient attendant, and we talk with them. We know them the emergency situation of the cases, aneurysm cases, and we assure them regarding the outcome. And we talk confidently with the patient and attendant so that they keep faith on us. And we also inform them regarding the risk-benefit ratio. And definitely, aneurysm management is a multidisciplinary management. We also counsel them regarding ICU management. So this is the one of the first cases, 68 years male with sudden severe headache, presented to us with ACOM aneurysm, ruptured ACOM aneurysm. In all the cases were ruptured cases. And this is the video. You see, there is the ACOM complex dissection going on. I'm a bit fast forwarding. This is the dissection on the neck to give space for the clip blade. You see, this is a very thin walled aneurysm. This was a left-handed clipping maneuver, and a bit angled clip was applied along the neck. And this millimeter by millimeter yaw and rolling movement has been done during the clipping. So this was a post-operative feature, and this is one of the unfortunate patients, and the 70 years female with ruptured distal anterior cerebral artery aneurysm, who presented with acute cerebral hematoma and hand and head grace free, with very poor GCS. You see on the preoperative scan, acute cerebral hemorrhage with gyrus rectus bleed, thick hematoma. And this is the operative video. We approached through intervascular fissure, right intervascular fissure. Then we encountered the proximal A2 for temporary clipping. Then we encountered the thick hematoma. First, we evacuate the hematoma for better visualization of the perianeurysmal morphology and anatomy. Then we got the aneurysm. We dissect the aneurysm around it was on the pericallosal callosomarginal bifurcation. And this was a very devastating case and a very angry brain it was. I'm fast forwarding it. And at first, we were not happy with the clipping. And you see the clip length hasn't covered all of the neck. And we again remove the clip and a bit remaneuvered to occlude the complete vessel. Then again a bit advanced the clip length according to the neck and reapplied it again. This is another case. There is a lady in the 50s, in the left middle cerebral artery aneurysm, ruptured case. This is the video. This is the Sylvian Fisher dissection. This was the left-sided pterional craniotomy and Sylvian Fisher, and also the dissection around the veins is going on. And we have reached the parent artery, that is the internal carotid artery, and further dissection going on. And we are using spatula to retract the brain on the frontal side. This is the temporary clipping on the A1. This is the dissection around the neck, the bifurcation, and an angled clip was taken when we got around the complete understanding of the neck. You see on the distal side there is a vein, and on the near side there is a efferent trunk which has been gone on to the Sylvian Fisher. After applying, we were inspecting the beneath the tip of the clip. Then we found that one of the efferent was got pinched with the tip of the clip. Then again, we remaneuvered it. You see, tip of the clip is pinching on the efferent trunk. Then again, we reapplied it. And now we are satisfied with the clipping. And we check always with the Doppler. You see the Doppler probe, as we don't have the ICG at our institute. This was the postoperative picture. Patient was doing good. And another case, 65 years male, Hunter has grade 3, presented with GCS 8. This is the video. Sylvian Fisher dissection. Sharp cutting of the arachnoid, and with also the intermediate arachnoid layers going towards the optic nerve. This was the aneurysm, right-sided approach, ACOM. We applied the temporary clip. Then the aneurysm got softened. We dissected behind the neck at the back door of the aneurysm. And also on the contralateral side, we applied the clip then. It was a bit angled clip to occlude the aneurysm. Patient was doing good on the post-operative day. This has improved. This was another case with Zaria sectus bleed. This was the position, and this was the video. This was another giant aneurysm, ACOM aneurysm. And during dissection, it got ruptured, and we put the temporary clip then, and softened the aneurysm, and again reapplied the clip. This was the post-operative scan. So we nowadays we use the paraoperative endoscopy in our institute. We have started using this, and I am also learning how to use it meticulously through Fujita Fellowship, and this is the inspection after clipping. And so what are the factors affecting outcome? GCS at presentation, WFNS grade, Huntington's grade, and if there is any vasospasm infarction at presentation. In our series, 67% patient were on good outcome side, fair outcome 23%, and poor outcome 10%. 7 patients died, 3 due to vasospasm, 4 due to poor GCS preoperative. So what I learned from my mentor, that is, it's the decision, not the incision. And it's a very every patient is individualized and approach is individualized. And doing the surgery before surgery, thinking about the surgery is very important. And how is our understanding changing over the time? On our initial days, we had used the retraction, but as the days go by, we try to do the surgery without retraction, as many journals showed that brain retraction gives contusion, ischemia, venous damage, or swelling. So we try to use without retractor nowadays. And in our initial days, we had to stand and do the surgery. Nowadays, we now sit on the operative side, and we do the surgery on a relaxed position, and we use endoscopy as well. So these are the understanding we just are changing nowadays along my career and along our neurosurgery career. So these are the some of the advice we took from our home and abroad professors and mentors. And what is our target, and how can we reshape ourselves in the future? We can add 3D fusion images, CFD, ICG, and also it's better to have a hybrid neurosurgery console as an armamentarium. So what is this days of future past? Along our career, we make mistake and we take a look back to our past. When we take a look back to our past, then our present time becomes the future past. That's how we change ourselves over the time and reshape ourselves as a surgeon. So that is my philosophy, that we look into the past, but from the past perspective, our present becomes the future past. That's how we change ourselves and furnish ourselves as a good surgeon. So now I am doing fellowship in Fujita Health University Banten Hospital. I am learning a lot under the guidance and of Professor Kato Sensei. She is just very much generous to us, and I'm learning CFD, practicing bypass every day, and learning a lot so that I can implement in our next coming days. And these are my residency time, my mentors, and these on the right hand side, these are my present working team in my National Institute of Neuroscience. So regarding aneurysm, it's that my conception is it's a time bomb, and we have to reduce the ictus to admission time and admission to clipping time, and always mentorship matters, and we have to be passionate, meditate, and execute us towards neurosurgery. Also, we need a DA team of equal patience, and we have to be down to our colleagues and mostly to our patients, and we have to be grateful to Allah and the Almighty for giving us strength always. Thank you very much for giving me time.
Thank you, Dr. Farah, for your excellent presentation in here. I was very well intrigued by the various diagrams that you had made prior to the surgery. In fact, I do have very vivid memories of Professor Sano, who used to draw each and every aneurysm before going into the surgery. What was the shape of the aneurysm, and which portion was it projecting? What was the type of clip that he would be using during the surgery? So what he used to teach was everything needs to be visualized prior to the surgery. You have to see the entire surgery before going into the surgery. It's all about the imagination. 40% visualized by the radiological images, 60% through your imaginative eyes. So I see that you are a wonderful artist as well. Just one thing, it's such a shame that in the subcontinent region that most of the aneurysms that we get are mostly ruptured ones. Your admission to clipping time at your center was 7 days on an average. What do you think are the main reasons that for having a patient for such a long period of time before clipping?
I think in our institute, I have shown that. Thank you for your question, and thank you for sharing your ideas. And in our institution, all the patients come to the emergency neurology unit. So neurosurgery department gets referral from the neurology, and we sit on Dhaka, that is the center of our country, and you patients are not so aware of this aneurysm emergency-ness, and that's why a bit delay occurs within the time. So in our institute, the protocol is first to the neurology, then to the neurosurgery, and the intervention department is under the Department of Neurology. So there's a bit delay time in between this administrative purpose.
Okay, sure. Yes. Any further questions for Dr. Farhad? Any comments?
Okay, can I?
Yeah, sure, please.
Can I have short comments? So I want to congratulate Dr. Farhad. Good presentation and very good academical level, good, very good analysis and good, excellent videos. And I like very much your allegories with the airplane and so on. So it's a great, very creative approach to creating the presentation. Also, you showed very interesting technique of forehand surgery of aneurysm. So also I noticed it's interesting. It's good. It means that you work very good with your assistant. So it's very good. You have a good surgical team when you do neurosurgeon work effectively in the one wound. It's very good. So thank you. My last comment. Unfortunately, the tendency in the world now is moving toward the more and more endovascular ways of aneurysm management. But we, as you're told, we take everything best from the past and try to implement it in the future. But also we must rely on the real situation in our countries. And unfortunately, the world is separated to low income, middle income, and high income countries. And nowadays, low and middle income countries is the field for neurosurgeons, for young neurosurgeons, to perform the open surgery, to develop their skills. Maybe only one exclusion from this from this how to say, from this tendency, the country, the Japan country, which is has a lot of resources, but Japanese neurosurgeon go on the open surgery and develop the surgery, and I think they show the best result and not worse the result than endovascular treatment. So I want to inspire you to go on, to move on, not to become lazy and give your patient to the endovascular surgeons, but develop your skills, go on and prove that open surgery is not dying. Now, it's really on. It's maybe it will share this the management of aneurysm with endovascular, and we must work together and not replace the aneurysm management by endovascular technique totally. So this is my comment. Thank you. Thank you.
Thank you, Professor Wozniak. Very kind and inspirational words for me. And I hope I would learn so much from you.
Thank you. Thank you. Good luck.
Yeah, thank you, Professor Wozniak. Any comments from Professor Kato, Professor Kimura, Dr. Haja? Yeah, Dr. Fawad, please go ahead.
Hello. Assalamu alaikum. Konnichiwa. Thank you very much,
Walaikum salam.
Dr. Farhat and Professor Ansari, Professor Kato, and Ben. Thank you, Dr. Farhat. Congratulations for your achievement. And it was, we are proud of you. And with learning purpose, and also thank you for Professor Kimura for learning and good excellent presentation, and it's very useful for young neurosurgeon. Thank you very much. Shukran. Arigatou gozaimasu.
Very nice Japanese.
Maybe one question. Raja, you want to ask something?
Yes, sure, Prof.
Please.
Thank you, Dr. Farhat Ahmed, for this wonderful presentation. One small thing I noted is you have analyzed the forking pattern in ACOM aneurysms. So is your center really choosing the open fork always for the ACOM aneurysms?
Yes, in case we analyze the fork anatomy, thank you for a nice question. Very important for preoperative understanding. There is a open fork. That means yes, of course, we analyze the open fork and we choose the side. Which side should we go? Not only on the dominance of the A1, and also for the anatomy of the fork, whether the A2 is lagging behind than the other, one than the other. And that's how we choose our approach. Also, we draw them before the surgery as if we will find it on the surgery. And then how we decide among our team. We go what are the plus point and what are the against point going through that approach. That's how we discuss regarding the fork anatomy.
Okay, but actually I don't believe in this forking, because what happens in ACOM is that when you suck the gyrus rectus, okay, this anatomy of this A1 and A2 changes totally. Okay, these are all movable structures, not some immovable structures in it. So once you suck the gyrus rectus, the forking anatomy changes. That's why I always choose the dominant A1 as the side of approach. This is one advice given to me by Prof. Michael Lawton himself. That's why I asked.
Yes.
Okay, so it's a congratulations, excellent talk. Yes, just I think the most of the case in your country, I think nearly the 100% is a cerebral hemorrhage, the unruptured case, I think. But I think the system is a bit different from ours. Maybe you should change, because no delay for the patient. And the most important thing to do the surgery is how you can obtain the stack of the brain. That is very important. So meticulous some tips, and also keep the cerebral perfusion pressure through until the discharge of the patient. That is most important. Prevent the vasospasm. That is very important. Thank you very much.
Thank you, Sensei, for the heads up.
It's really nice.
Thank
Yes, thanks so much.
Thank you all. I think we should now move to the last presentation for the evening today. I would like to invite Dr. Yi Gao, who is currently an associate professor of neurosurgery at the Tsinghua University, Beijing, China. He is also the present deputy director at the Department of Neurosurgery at Tsinghua University affiliated Beijing Qinguang Hospital, China. Please, Dr. Go.
Okay. Yeah. Thank you very much for the introduction, Professor Ahmad. And I'll show my screen. So can you see my screen?
Waiting.
Yes,
now we can. Please make it full screen.
please make it in presentation mode.
It shows the temporary pause. I'll try again. So can you see?
Yes. Yes.
Okay.
It's a bit zoomed in mode. Can you zoom out a bit? It's not perfectly fit to the screen.
I think it's okay. We can see.
I'm sorry.
Yeah.
Please continue, please.
Okay. Okay, thank you. Professor Yokado and the colleagues, it's my pleasure to be here. Yeah, and today I will share the topic is the treatment of complex scalp vascular malformations with or without the intracranial extension. And the scalp vascular malformations are rare lesions with abnormal vascular vessels, often presenting incidentally. As a result of their widespread flow-dependent abnormalities, these lesions can present with concomitant arterial venous fistulas and intracranial extracranial connections or intracranial vascular lesions. And these lesions can present congenitally in a delayed fashion after trauma or iatrogenically. Careful evaluation is recommended before endovascular or surgical treatment. And the presence of intracranial communications of the scalp arterial venous malformations or concomitant intracranial abnormalities can affect treatment strategy and timing. And today I will share three cases, three complex the scalp malformation cases. The first one is the sinus pericranii with vein of Galen malformation. The patient was the 24-year-old female, and she had a scalp mass on left parietal area since infant, and masses enlarged with age. And she was accepted sclerotherapy for left eye vascular malformation, but useless. And she suffered a distending pain of masses and felt weakness in the right leg when walking in recent 1 year. And the physical examination revealed no neurological deficit. And this is the patient CT angiography reconstruction. And we can see in her left scalp, there are Marty lump on the left side area. And this patient has a vascular malformation located in the left eyelid, left barba conjunctiva, and the left tarsal conjunctiva. And we can see she had a multi-soft lump in left scalp. And when she sit up, and this mass disappear quickly. And we do detailed evaluation before surgery. Now we can see the CT angiography reconstruction. There are multi areas of the left scalp has indentions, and there are very small, a lot of those very small holes in the skull. And ultrasonic examination revealed the communication, the small vessels transpassing the skull. And she also had a vein of Galen malformation, and the DSA showed the mass didn't see on the DSA examination. And this is the surgical plan. We do a T-shape incision, and in the extracranial periosteum, there are the mass. After we remove it and coagulate and wax the small holes on the bones. And after the surgery, 3 months the follow-up, we can see the those lumps disappear, and the vascular malformation in the left eye shrink. So for this case, it's a sinus pericranial. Is a rare disorder characterized by a congenital epicranial venous malformation of the scalp, and it is viewed as a rare extradural venous anomaly, whereby an abnormal connection is formed between the intracranial dural venous sinuses and the extracranial venous system through an emissary or diploic vein. This abnormal communicating channels redirect venous return to the extracranial periosteum, resulting in swelling of the affected region, and on palpation, soft, compressible, and collapsible masses. And surgical correction of the sinus pericranial involves the resection of the extracranial venous masses and ligation of the emissary and the diploic veins. Also, we use coagulation and wax to deal with these communications with the affected dural sinuses. And endovascular treatment is referred to the as a second choice, as it provides less control when traversing the intracranial venous circuits and into the region of the sinus pericranial. And the second case is a giant scalp arteriovenous malformation. And this patient was a 64-year-old male, and she had birthmarks on scalp when born, and then enlarged with age. And there were ulcerations and ruptured repeatedly over the years. And he was underwent 2 surgeries for ligation of left superior temporal artery and the left occipital artery and the right ECA. And the mass size reduced temporarily and enlarged again. The vital signs are stable, and all other systems were normal, and the blood investigations were unremarkable. And the physical examination revealed no neurological deficit. And this is a patient, the picture and the reconstruction of the CT angiography. And we can see there was a giant soft reddish in the 19th lesion in the right temporal parietal area. The overlying skin is coarse and dry, and there were ulcerations and active hemorrhage present. And after we do the detailed reconstruction, we can see this is the giant vascular lesion, and his supplied arteries mainly from the right and right superior temporal artery and the right occipital artery, and also the left SDA and the occipital artery feeding the lesions. And there are many very large draining veins from the many directions. And there was no intracranial draining veins. We can see from the each directions to see the feeders and the draining veins, and this is the giant vascular lesion. So the surgical plan is a staged operation. The first stage, we ligate the multiple main supplied arteries to reduce the bleeding, the second stage operation. And then we arrange the second stage operation to complete removal of the lesion and the skin grafting. And this is the second operation. We remove the giant lesion, and here we do the extension incision to expose the right the superficial temporal artery, and this is the large right occipital artery and the draining veins. And after remove the lesion, the plastic team acquired the donor skin. The donor skin was taken from the patient's back, and the two split thickness skin grafts was harvested from the patient's back and covered the large area of the damage of the skin by plastic surgeon's team. In the 5 years follow-up, we can see the lesion removed totally, and the scalp healed very well. And the third case is a large scalp arteriovenous malformation with intracranial dural arteriovenous fistula. This is a 60-year-old male, and he was underwent the first endovascular embolization 26 years ago due to enlarged frontal arteriovenous malformation. And he was underwent the second and the third partial endovascular embolization therapy 15 years ago. But the arteriovenous malformation size reduced temporarily each time and enlarged gradually after the embolization. In recent 6 months, the mass enlarged obviously and ruptured repeatedly. And the patient has no neurological deficit. And this the CT angiography reconstruction. We can see she had a right frontal area, the large scalp mass, and the mainly feeders is from the arteries of the scalp. And there are some holes on the right frontal bone, and the lesion, the vessels communicate with the intracranial the vessel system. And here, there we can see there are some holes in the right frontal bone, and through the bone, the lesion, the scalp lesion, communicate with the vessel system in intracranial. And this is a DSA reconstruction. We can see the frontal arteriovenous fistula located in the middle line. And this is the DSA. This is the left internal carotid artery angiography, and this is the right frontal right ICA angiography and the ECA angiography. And there are some the middle meningeal artery supply from the right side. And this is the MRI evaluation. We can see this is the scalp lesion and the communication through the frontal bone and the abnormal vessels, the drain to the deep vessel drain to the deep system, the vascular system. So the surgical plan is the hybrid operation by multidisciplinary teams. The step one, the first step is the endovascular team embolize the right middle meningeal artery to reduce the supply, the blood supply. This is the intraoperative DSA. The middle meningeal artery was embolized with onyx. And then the neurosurgeons team removed the scalp arteriovenous malformation lesion and performed by frontal craniotomy to remove the dura arteriovenous fistula. And this is after the remove the dura AVF, we can see in the ICG angiogram, the draining vein lost the blood supply. And the third step, the endovascular team performed intraoperative DSA to confirm AVM and AVF disappear. And this is the right ICA angiogram, and this is the left ICA angiogram. We can see the scalp AVM and frontal dural AVF disappear. And the last step, the plastic team continued to remove the lesion, and the superficial temporal artery island flap rotated to reconstruct the defects of the right frontal area, and the residual raw area was then resurfaced with thick split thickness skin graft harvested from the thigh. And this is the postoperative CT angiograph reconstruction. We can see this is the superficial temporal artery to the location was moved forward. And this is the embolization middle meningeal artery. And the dural arteriovenous fistula disappeared. And this is 3 weeks after the surgery. So for these 2 cases, the take-home message, the scalp has the thickest layer of skin in the body, and the scalp arteriovenous malformations account for 8% of all arteriovenous malformations. And the scalp AVMs mostly originate in the subcutaneous layer of scalp, which contain the vessels and the nerves and rarely has intracranial extension. The patients present as a throbbing pastel mass with headache and cosmetic deformity. Although embolization is the first-line treatment for arteriovenous malformations, but for these cases, the complete surgical removal of the lesion has its value because the best outcome with low recurrence rate. Also for the cases which failed embolization treatment. And surgical treatments include a simple surgical excision, dilator therapy, and skin grafting after surgical excision. And individual surgical treatment based on the clinical stage and angio architecture type can achieve satisfactory results in scalp arteriovenous malformations. In massive scalp arteriovenous malformation cases, when scalp preservation is not possible, reconstruction of scalp becomes very important. So multi-specialty and multi-modality treatment is essential for such challenging cases. That's all. Thank you. Thank you all.
Thank you, Dr. Yi, for your wonderful presentation on a very occasionally talked about topic. I would say that we do get quite a few numbers of scalp AVMs, but one of the most frequent encounters that we get in our scenario are middle-aged females who present to us with some swelling over the scalp region. But because this swelling is overall covered by the hair, by the hair, they are not too much concerned over it. So my first question is, when exactly is your recommendation to go in for treatment of excision for these scalp AVMs, as not all of these lesions would be presenting with any severe hemorrhage or going in for an ulceration? And second, how do you think about the recommendation that quite a few interventionists are doing these days about injecting sclerosants directly with the help of a USG over the scalp in these lesions?
Yes, because this we only dealt with the 3 cases. Most scalp arteriovenous malformations was treated by the endovascular embolization, and they can be treated well. But this case is a repeated recurrence, so it cannot be treated by the endovascular embolization. So we try to resist these lesions. But as you see, the 3rd case is located in the frontal area. If we transfer the flap, it's the cosmetic problem, and the hairline will move forward. But we discussed these problems with the patients and the relatives. They accepted, and the plastic surgeons team, they recommend after the patient healed well and remove the hair from the forehead. So we have no too much experiences to deal with such challenging cases. Only the 3 cases. So we now to try to communicate with the other surgeons to give us some suggestions.
Yes, sure. So one of our colleagues, what we were doing recently was injecting these fluorescents directly into these lesions. So the main idea of for even going with an endovascular treatment was to offload the lesion. So even in some of these cases in which we are not having very significant dilatation of the vessels over the scalp, injecting a sclerostin directly over the scalp region, over the affected vessel with the help of a plain USG or a Doppler, and waiting for some time, this might completely thrombose the vessel. And we have seen I think one or two cases in which complete thrombosis has also occurred. Of course, they were not very huge lesions that like the ones that you have recently shown in.
You mean during the surgery, inject the
Prior to the
onyx?
Prior to the surgery, with the help of a USG, directly injecting the sclerostin into the lesion.
Yeah. We do not try that method because during the surgery, we can easily to control the bleeding around the lesion to coagulation the supply arteries or ligation the supply arteries. So we try not to, because it injected the like onyx in the lesion, such lesion, the high flow, we cannot control its spread area. Yeah.
Of course. Yeah. Thank you. Yeah, Dr.
Yes,
Sam.
thank you.
Please go ahead.
Hi, thank you, Prof. Ansari. Thank you so much, Prof.
Yeah.
It was an excellent talk. Very impressed by your results. I'm very interested in this topic. I have quite a few patients on this. I have 4 questions. First, when we do excision, I think one of the most common complications is skin breakdown. How do we avoid that if we were to excise it? That's one. Okay, we said when they are very large, you tend to have to excise the full thing and ask a plastic team to replace the skin. So when do you decide when it's too large and you have to do that versus just simple excision? And the next one will be, I think one of the cases you said the first stage you tried just ligation alone instead of excision straight. So when do you decide if maybe you just try ligation first of the feeder arteries and or just go in straight for excision during the same surgery? And last but not least, yeah, some people say that endovascular may be the first line, but some people prefer excision as the first line as they don't recur. But of course, these other complications like a wound breakdown may occur. So what are your thoughts on that as well? Thank you so much.
Yeah, that's excellent questions. And these questions are the problems we met during to deal with these complex cases. And because we don't have experiences for dealing with such cases, so we tried the different methods, like the first the scalp AVM patients. We just use the strategy of the intracranial AVM, the surgery procedures, like to cut the supply, blood supply, and remove the lesion, and ligate the draining vein, the procedures like this. So because we don't know if we ligate the feeding arteries, what happened after ligate the feeding arteries. We don't try to in the same procedure. So we selected the stage of the sedation, the two stage. So first we use a small incision to ligate the mainly the main supply arteries to see if the lesion if the skin breaks down or the lesion shrink, become soft to reduce the blood supply. And after we ligate the arteries, about 2 to 3 days later, we give him the second operation. The lesion didn't shrink too much, but it became a little bit soft. So we tried to remove the lesion, the second operation. But the last case, the lesion is not too much like the second case, but it communicated with the intracranial vascular system. So we tried to do in the same operation. It's the same procedure. The lesion, when we incise it, it not bleed too much. But when we deal with the bone holes here in the frontal bone, it bleed a lot. We use a lot of wax to seal the hole to stop the bleeding, and then craniotomy. So how large the size we decided to make grafting? Because, I'm not sure the exact size, but after we evaluate, if we transfer the flap cannot seal the lesion, we discussed with the plastic team. They recommend we should use the grafting procedure. So we tried in these 2 cases. The first one we don't need to grafting. We just the linear incision to remove the lesion.
Okay.
Thank you.
Okay, thank you.
Yeah, I can see Dr. Ben here. Please go ahead.
Yes, thank you. Thank you for your quite very interesting questions. And I'm also have some interest in it. And my first question is about if you have recurrent cases after the after embolization and excision. So usually, how would you manage it? Because you have already have reconstruction over the scalp already. So maybe further surgical excision might not be feasible, and also endovascular may not completely cure the condition. My second question is about because sometimes we need to consider embolize or ligate the fetus, as mentioned by you. So in case we need for reconstruction of the scalp, sometimes the plastic surgeon might consider using the free fab. So can I ask, is there any experience in your center using those free fab reconstruction with the scalp? And usually how what is the donor vessels and the veins, and how do they tunnel the free flap?
Yeah, that's good questions. And the second question, we use the how to say that the STA island flap, and they just split the skin on the surface of the STA to and then to remove the island to move forward. But the skin here, they just flap, and then they yeah.
But sometimes, like for the free flap, if you don't have that STA island flap, then you might need to consider doing the free flap.
Yes. As the first case, we use the free the flap. No, the grafting.
Yeah.
the first case, the defect is a large size. We cannot using the scalp flap to reconstruct here the defect. And for the recurrent the case, now we only deal with these 3 cases, so we cannot face the recurrent cases. And the first large scalp AVM case is about 5 years ago. We performed the surgery, and the picture, the photo is 5 years ago, 5 years later. So the patient didn't recur. So we're now to try to deal with much more these complex cases to gather the experiences. Thank you.
Thank you so much.
Any comments from Professor Wozniak, Professor Kato, please?
Okay, thank you. Thank you, Professor Yegu. Great presentation, really very rare and very tough cases. I cannot comment this case like this because actually every case is very individual and requires a very specific approach for the manager and by the big team of endovascular surgeons, neurosurgeons, and plastic surgeons. Maybe I just have a question about the second case. When you evaluate the patient before the surgical procedure, do you perform the selective angiography, and do you evaluate the small skull-based vessels like branches from ethmoidal, from trigeminal, and so on, small arteries which penetrate the skull base? And how do you manage it because anyway usually they are involved in all this huge AVM. Do you recommend to obliterate them also endovascular the same procedure or you just observe the patient and take a decision afterward after the main procedure?
Thank you so much for the question, Professor Wozniak. And yeah, that's for the first question. The first patient, the large AVM. We performed the digital subtract angiography. There is a pure extracranial lesions, no intracranial the vessel abnormal. So we only deal with the scalp lesion. Yeah. And the second case is the dural AVF, and we evaluated pre-surgery, and the blood comes from from the sorry. Yeah. And the endovascular surgeons they evaluate if the embolization will influence his eyesight. And 15 years ago, he underwent the embolization. The patient's eyesight decreased. So we after the discussion, we tried to perform the surgery directly. Yeah, and the intraoperative DSA, the AVF disappeared. So we need to long-term follow-up.
Okay, thank you very much. Thank you, and congratulations. Really difficult cases. Thank you, and
So Dr.
congratulations.
Thank you very much. Dr. E, it was wonderful talk, but from my very limited experience, not a scalp, but the patient has a finger skin. So, so that they cannot complete cure. So the day by day, so the growing of the some fistula, so amputation on the finger, so step by step. So that means I think it's quite difficult to complete cure of this lesion. I think. What about the radiosurgery? So the paper for treatment of radiosurgery?
Yeah, I don't know about the radiotherapy for such cases, but I think the size of this large high flow lesions, especially the ulceration and repeatedly rupture, I don't recommend the radiotherapy on the first line. Maybe for
not the first line, of course. Yes.
Yeah. So yeah.
So, or maybe some drug for cessation to the growth of the some kind of the growth factor, something like that, in the future. Yes.
Yeah.
We must find some good solution for the complete cure of the disease, I think. Thank you very much.
Yeah, so I want to communicate with different disciplinary the doctors to get some recommendations.
Thanks so much.
Thank you.
Yeah, thank you, Professor Go, Professor Kato, Professor Wozniak, all the participants and all the speakers today. It was truly a wonderful evening discussing through a wide spectrum on cerebrovascular diseases, and we look forward to having more such meetings in the future also. Thank you all. Thank you.
Thank you.
Thanks so much. Hi, Chen. How are you?
Yeah, hi. Long time no see.
Where you are now? Yeah, are you in Los Angeles or where are you now?
Currently I'm back to Shanghai visiting my parents. Yeah, but next week I will back to LA for postdoctoral. Yeah.
So sometimes maybe you can email us what you are doing there.
Yeah. I will recommend my senior neurosurgeon in Renji Hospital. He's very professional in endoscope, and I hope he want to share some endoscope experience with ACNS members. So we will talk in by email in the later.
Yes, please. Thanks. Thanks so much. So happy New Year. All the best in 2024.
I always learn a lot.
It comes to the end of our webinar. So on behalf of the Educational Committee of ACNS, and I would like to thank you all for joining the webinars tonight. And today we have a very meaningful, interesting discussion and also the topics. And I would like to thank the chair, Professor Ahmed, and also our speakers today, Professor Kimura, Dr. Farhad Ahmed, and also Professor Yigo, and also our discussant today, Professor Lisan and Professor Priscett. So again, thank you so much. Thank you all of you for joining tonight, and I hope to see you all in the next coming webinars.
Okay, bye-bye.
Was for me.
Thank you.
Arigato.